and realize that my presentation had actually crashed. I closed my computer in the morning and hadn't saved the stuff, and it was gone. So you have probably seen me sitting outside trying to reconstruct what I had. And what you see here is a pretty good approximation of the previous presentation that I intended to give you. I will talk about imaging of acute stroke, and I will focus on some of the new developments which you might not be completely familiar with, which are especially focusing on perfusion imaging with CT. And one of my main collaborators is Brigitte Veldhuis from Utrecht, where I used to work till about 2 years ago. Now, some basic information about acute stroke. It is, per definition, a focal or global disturbance of cerebral function that is rapidly developing and is lasting more than 24 hours or is leading to death. There is no apparent other cause than a vascular origin. In contrast to that, a transitory or transient ischemic attack is a stroke that lasts less than 24 hours. Usually, it results much faster, within minutes or a very few hours. On the other hand, a non-disabling stroke is like a TIA that lasts for more than 24 hours, but resolves completely and leads to no permanent disability. If you look at the incidence and prevalence of stroke in Great Britain, in England, there are about 20,000 transient ischemic attacks per year in Britain, and about 110,000 strokes. And half of these people die. So it's a real major health issue. Total of all deaths in England, 10%, more than 10% of those are due to stroke. The most disturbing thing, however, is not so much that you die, but that quite a few people survive, but are massively morbid and need help from others to be able to do their daily things. They're massively incapacitated. And in Britain at the moment, there are almost 1 million people living with the sequelae of stroke, and about half of them need help in their everyday duties from other people. If you look at the two big causes of stroke, about 2/3 are due to ischemia, and about 1/3 is due to hemorrhage. Now, if you look at ischemia, arteriosclerosis is one of the major factors that leads to stroke, be it directly or indirectly. Embolic reasons can also lead to stroke when a clot comes from somewhere and ends up in the brain, but also dissection can lead to stroke. There is hemodynamic stroke, which basically means that blood pressure becomes so low, the vascular territory in the brain is so bad that areas that are between two territories get less blood, and that gives you hemodynamic strokes. And then vasculitis, of course, also can lead to stroke. If you look at hemorrhage, then hypertension is the main reason for that. The vast majority of strokes due to hemorrhage are caused by hypertension. But there are a vast number of other causes, and you see that aneurysms, arteriovenous malformations, venous thrombosis, vasculitis, amyloid angiopathy or tumors also might lead to stroke due to hemorrhage. Now, the imaging modalities that we have are, on the one hand, CT, and in the olden times, we were using only non-contrast CT for stroke imaging. This is actually not very sensitive. I'll show you a few examples. What is coming up nowadays is CT perfusion imaging and CT angiography for evaluating the vasculature with it. Ultrasound was frequently coupled to CT or to MR to evaluate the carotids, because if you have a patient with stroke who is again stable, you would like to operate on his carotid as quickly as possible if you find that the carotid is stenosed. And finally, if you have a stroke, usually echocardiography is performed to make sure that there is no reason for an embolus coming from the heart, for example, a thrombus within the left ventricle. And then you have MR, which basically focuses on the detection of stroke and not so much on the vascular reasons behind it, like the carotids or the heart. You can do it with T1 or T2 weighted, or actually not, you have to use all of them. T1, T2 weighted images, FLAIR diffusion weighted images, and MR perfusion or perfusion weighted imaging. And this gives you the chance also to look at T1A images after contrast to see whether, for example, a bleeding is still active. The role of imaging is to differentiate, first of all, ischemia from hemorrhage. There are some clinical signs that will make you look more into the direction of hemorrhage because this gradually evolves and gets worse over time. Ischemia really starts very rapidly and not as gradual than hemorrhage. It also helps you define the extent of the disease, may identify the potential cause, select the treatment, and help prevent recurrent stroke by, for example, looking at carotid stenosis and making it possible to treat this. Let's have a first quick look at intracerebral hemorrhage, but this will not be the thing that I will be focusing on. When we look at the role of imaging, we would like to differentiate whether it is a hypertensive bleeding or a bleeding due to amyloid angiopathy, whether there might be a vascular origin. In other words, do we see an AVM or an aneurysm or signs of vasculitis, or is there even a tumor? All these things we can see from imaging. We would like to define size and location, that's clear. Another thing that's important, if you can see active bleeding, this means that the prognosis is very bad. Active bleeding means expanding hemorrhage, and the prognosis of these patients is much less favorable than patients that do not bleed actively. This is something that we've learned in the past years. There is not yet systematic treatment, but maybe at one point there might be something for interventional radiologists to do there. But at the moment, that's not done. Then, of course, signs of increasing intracranial pressure, which will give you an indication for surgery. And prognosis I already mentioned. Now, here's the classic situation where you do see a number of hypertensive bleedings, and you can see some of those have broken into the ventricles, others are still intraparenchymal, but all of them are sitting in the parenchyma and not in the cortex. If you do see cortical bleeding, then the chance is very high that this is amyloid arteriopathy, angiopathy that is the cause of this bleeding. AVMs can be another cause of bleeding. Here you see a T2 weighted image, here a gradient echo, and you see that there is a little bit more black than you would expect. So this thing has been slowly but surely bleeding a little bit into the brain tissue. And so this is something obviously that needs to be treated. You also see that it has some massively dilated vessel. The nidus is actually aneurysmatically dilated. And you can see that MRA is an excellent tool for visualizing that. These small amounts of blood that you can see here are extremely hard to detect on CT and usually are missed. Now let's focus on ischemic stroke because this is the area where there is the most things going on and that is the most dynamic and where we can contribute to appropriate treatment. What we would like to differentiate here is, of course, the cause, whether it's a territorial, an embolic, or a hemodynamic stroke. That is not always possible, but very frequently. We would like to define the size and, again, the involved arteries. And then an important thing is we would like to see what is the dead tissue and what is the tissue at risk. We would like to estimate the risk for secondary hemorrhage. In other words, if we treat, will the patient actually get a hemorrhage and actually not benefit from our treatment? Decide whether the thrombolysis should be intravenous or intraarterial, and then look at carotid stenosis or detect embolic cardiac causes. If you look at the natural cause of stroke, then you have the necrotic phase in day 1 to 3. Here you have hyperperfusion that leads to a loss of function. But at that time, the cells are not necessarily dead. After a while, if the hyperperfusion continues or there is no blood at all that goes to a cell, then it leads to cell death and ultimately to cytotoxic edema. And about 6 hours after the stroke, you'll find a loss of blood-brain barrier with vasogenic edema. And leukocyte infiltration starts about 1 day later. Here's an example that shows you a non-contrast CT of an acute stroke. And as you've probably all seen here is classic situation. You see this area here in which there is a loss of weight gray differentiation that indicates ischemic tissue in this area. In the resorption phase, which is from day 4 on, the necrotic tissue will be kind of broken off and phagocytosed, and the edema is actually maximum around day 3 to day 5, which is also the time when patients that have a massive hemispheric stroke, let's say of the media, have the biggest chances of getting complications like herniation of the brain. If you do some imaging during this time and you decide to give contrast, you will frequently find these enhancing areas because of the leukocyte infiltration, which is now so strong, and the loss of the blood-brain barrier, that you do see contrast enhancement in this region, which at some point will make it difficult to distinguish that from a tumor. So the classic anamnesis plus the imaging on the non-contrast scan is enough. In the organization phase, you'll ultimately develop glias scars or cystic infarct residuum, and the classic situation is that where you see very dense cortex and large areas that contain almost nothing. To decide whether something is a territorial infarct, a hemodynamic infarct, or a lacunar infarct, you'd have to look at the shape and the size. And the classic situation is if it follows territories, perfusion territories, it's a territorial infarct. If it sits just in between two different perfusion territories, it's a hemodynamic infarct in which the watershed areas are involved. Watershed areas are these areas that are just between two perfusion territories. So if blood pressure drops massively and you have a bad vascular status, these areas are the first ones that do not get enough blood. This can also involve the deep areas within the white matter. Lacunar infarcts are small lesions, usually in the deep white and gray matter, and they can be either embolic or arteriosclerotic, depending on the orange. So small vessel disease can cause that, but also small emboli, a shower of small emboli might also cause that. You all know the perfusion territories, but what's important to point out is the by far largest perfusion territory is the media territory. It contains most of the brain tissue, so if the media is involved, which it is in most cases, we get the most damage. Anterior infarcts contain much less problems, or make usually much less problems up here. And these territories are luckily variable. That means that all of us will have different territories. Some of us have more, which is perfused by the media. Others will have more that is perfused by the anterior circulation or the posterior circulation. And how much that is the case depends also on the circle of Willis, whether the circle of Willis is completely patent or whether they are hypoplastic or missing segments. That also tells you something about collateral circulation, which gives you a potential for getting less severe symptoms if you have good collateralization and an occlusion of, say, the medial cerebral artery. Classic CT features are the dense vessel sign here and completely occluded media. Then you see the very early features, and if you look closely, you see again here a white-gray differentiation, and you see that the white-gray differentiation in this area is reduced. But you see that it is very subtle, very hard to detect, and if you ask two of us where exactly the borders are, it is very likely that we will tell you something different. So the inter-observer variability in deciding where the ischemic area is very large in these first stages. What helps, however, if you turn down the window really dramatically to a very, very narrow window setting, that helps you identify these early changes. And then if there's already a manifest infarct, you just see this large hypodense area. Now, non-contrast CT or MR, the answer is very simple. If you have this choice, MR is the way to go. Same patient, very shortly afterwards, after this non-contrast CT, which was absolutely normal, an MR was done, and on the diffusion-weighted image, you see this abnormality, which indicates an area of stroke. It is important to say that also on the FLAIR and the two-weighted images in this patient, nothing was seen, just diffusion-weighted imaging was able to show this abnormality. So diffusion-weighted imaging is extremely sensitive for picking up these early changes. Now, here we see a couple of FLAIR images and T2-weighted images, and down there, diffusion-weighted images from different patients. Here's a classic territorial infarct on a T2-weighted image. Here you do see two infarctions on a FLAIR image in the area of both anterior cerebral arteries. If you see that, then this is not a classic infarct, but a secondary infarct in a patient who had an aneurysm of the anterior cerebral arteries that had been clipped. Actually, it had been clipped successfully. The arteries were still open, and then the patient developed a vasospasm. So the vasospasm caused that infarct. And vasospasm is the biggest problem in the treatment of subarachnoid hemorrhage patients. This is a really tragic case of an infarct, again on a T2-weighted image in the region of the brainstem, pons area, and this patient is locked in. So basically, there's no way that we know what he's thinking or doing. He can't do anything. These are two images from the same patient, and what you do see is small cortical infarcts on a diffusion-weighted image and a few deep white matter infarcts, relatively peripheral. Now, if you look at this distribution, what should come into your mind is that this is very likely an embolic source that shoots small emboli into the brain. And finally, something that is almost impossible to see on CT is this infarction in the brainstem, again, in a situation where you see on diffusion-weighted image